Now, when I first started working with Paltop, I did some of my own testing, some of my own benchtop testing. And I said, okay, listen, these are the implants I'm used to placing. I place Straumann, I place Nobel, right? I place 3i. And I said, okay, let's see in some kind of benchtop objective test, at least for me, right? Are there things that I can measure myself, right, to determine and see, is this an implant that I want to go ahead and utilize? So I looked at 3 tests, 3 things that I can measure on the benchtop. One is extraction torque. 2 is insertion torque, and the 3rd is what's called an ISQ value, right, which is measurement of mobility of the implant. And so I took a block of bone. It's called saw bones, right? It's simulation bone. I can order it in D1, D2, D3, D4, right? And I went ahead and I took implants from each of those companies, right? Nobel and Straumann, right? 3i and Paltop. I used each of their surgical kits, and I placed the same dimension or approximately the same dimension implant using each of their protocols, and then assess the implant through extraction torque, insertion torque, as well as, Ostel value. And if you go and you look at the numbers, you look at the bars, okay, I'm not sure if you can read it from there, okay, but, the blue is 3i, the yellow is replaced, the green is Straumann, and the red is Paltop. All the implants did well, okay, all did well, but if I look at the extraction torque, right, that means if I try to turn the implant after I put it in, so you'll see that, Paltop has the highest number, but basically equivalent, I'll call it the same as Straumann, and all the implants were somewhat similar. 3i a little less. If I look at the insertion torque, right, the amount of torque, and that's usually a measurement we use to see if we feel comfortable of implant stability in terms of immediate placement or immediate loading, right? So if we look at Paltop, we have a number of 43, which is good. I'd like all my implants to be somewhere between 30 and 50 Newton centimeter, right, in terms of insertion torque. So in dense bone, right, this is D1, D2 bone, I'm at 43, right, with Nobel, replaced being at 48. So again, approximately the same, did well. And in terms of Ostel or ISQ mobility, right, measurement of mobility within the implant at that time, right? So all the implants did fairly similar with Paltop, and Straumann and Nobel having similar numbers. Well, what about poor bone, right? Because a lot of implants do well in bone that's good. So what about bone that's a little bit poorer? So if I look at D3 bone, here I'm looking at D3 bone. If I look at extraction torque, Paltop, 30 newtons, well, that's pretty good in D3 bone, right? If I look at, the ISQ or Ostel measurements, right? So we're looking at 61, 64. Everyone did about the same, right? And if I look at the insertion torque, Paltop is at 30 as opposed to the lower insertion torques. So I felt comfortable saying, okay, I'm going to begin this journey placing Paltop implants because I have good objective data. And now over 3.5 or so years of placing the implants, I place it in all different types of scenarios. And just some of my initial numbers, this doesn't include my probably last half year or more of data of 300 plus implants, including all patients, whether they're diabetic, bisphosphonate users, smokers, steroid users. I haven't excluded anybody from these numbers, right? Extracting teeth, immediate placement, immediate loading, engrafted sites and sinuses in all different areas, okay? We look at that point, we had 13 failures out of those 300 plus implants for a success rate of approximately 96.5%. If I took out my, let's call it immediate load failures, right? We went to 98%. And if I took out my smokers and long-term steroid users and extraction, 99%. So it certainly falls in line, right, with success of all the different centers. But if you take not just my data now, and I look at a 5-year multicenter study, right, over 1,000 implants reviewed, right, 463 people, about even men and women, 17 to 92 years old. Again, nobody excluded from the study, right? Not selecting the patients that are going to be successful, but including even the medically compromised patient. If we compare the mandible to the maxilla, right, we're at about 97% success. Varying bone densities, D1, D2, D3, D4, right? 93%, 98%, 97%. D4, wow, look at that. In the poorest bone, we did the best. Well, you start thinking about, why is that? And again, there aren't big differences in the numbers, but by Paltop design, it has compressive threads and not cutting threads. Cutting threads, although we do have one implant, and we'll talk about that in just a minute, compressive threads are going to go and push the bone as opposed to cutting the bone, and that's going to provide more stability in poorer bone. If we look at 1 stage versus 2 stage, meaning burying the implant or putting a healing abutment on it, right? Again, we're looking at 98% or so success. If we look at placing it into extraction sockets, right? 1 stage, 95%, 2 stages, meaning bury the implant, there was 100% success there, okay? putting it into healed bone with an amount, immediate loading. Again, we're looking at statistics that fall in line with successful implant types. Certainly we're looking at 96, 97, 98% success that I've experienced, as well as other centers in this multi-center. Okay, all different types of things.